Welcome to tonight's webinar. My name is Dan Dunford. I'm a Senior Global Marketing Manager at ALIF and will be your moderator. ALIF is one of the largest human tissue providers in the US, creating innovative dermal, cartilage, tendon, fascia, bone, amniotic, and living cellular allografts to help heal patients. Since 1994, the company has continued to advance its allografts to improve patient outcomes, serving as a trusted tissue partner to the medical community. We have an excellent guest speaker with us this evening to discuss his experience using amniotic membrane as a barrier to assist the body in minimizing scarring and adhesions, and how this benefits the patient and spine surgeon. This is a timely subject as the number of spine fusion procedures is increasing year over year in the United States. I'm pleased to introduce Dr. Jonathan E. Schoeff. Dr. Schoeff is a spinal access surgery specialist who has dedicated his practice to improving overall quality and care for patients undergoing anterior spine procedures. He is the founder of Rocky Mountain Advanced Spine Access, serving patients throughout the Denver metro area, and has performed over 3,500 spine exposure cases to date. Dr. Schoeff's surgical practice focuses on optimally invasive spine exposure, recognizing the anatomical nuances from patient to patient and focusing on the least invasive technique to achieve optimal spine exposure while minimizing morbidity and negative sequelae related to the approach. To our audience, all questions will be taken online, so please make frequent use of the Q&A button at the bottom of your screen. Click the button and we will monitor the questions during the presentation. Once Dr. Schoeff's presentation is complete, there will be time to answer your questions. Dr. Schoeff, thank you for joining us this evening. Could you start by telling us, how did you become a specialist in ALIF access surgery?
So Dan, that's a great question. To be honest, depending on how you look at it, I think it was sort of dumb luck or maybe fortuitous as far as how my practice has evolved. But I think I probably started out very similar to most people doing high volume spine exposure like myself. And that is, friend needs a helping hand. And a lot of really good and really bad conversations start that way. You know, when you go to help out your buddy, there's, with a relative lack of experience, you may be perfectly well-intentioned, but it leaves a lot of opportunity for risk and complications that arise. I really made a decision about 7 years ago to solely focus on spine exposure procedures because I felt like for me to provide the level of care that I wanted to and felt compelled to for my patients, I had to understand these operations inside and out. But to take it a step further, I really had to hone in on spinal access surgery as a field of expertise. And I think that's a growing interest across the country, but it's something that's still severely lacking. And, you know, when you consider sort of the challenges to spinal access surgery as a discipline, I think it starts out with a lack of standardization. There really is no formal training for spinal access surgery. A lot of us, unfortunately, have to learn on the job, and much of it becomes self-taught. And even when I look at my practice, you know, starting with the first 300 to 500 cases that I did, my rate of major vascular injury, which is kind of really, I think, the mark which we have to qualify ourselves by, was upwards of 10%, which to me, looking back, is totally unacceptable. Right now, my practice, including that original 10%, at 3,500 cases now, I maintain a major vascular injury rate of less than 0.1%. And then when you look at the educational opportunities that do exist, which there are some, but in truth, it's a weekend course, and you know, I teach them, my colleagues teach them, and you know, then you have to sort of pat someone on the back and say, "Go get them." And I don't think that's really adequate in terms of preparing things.
Thank you, Dr. Schoeff, for that explanation. Could you elaborate on how you find spine surgeons to work with and how you collaborate on patient care?
There's a lot of what I would term cold calling. It's knocking on doors. It's introducing yourself and what your skill set is and what experience you bring to the table. But it ultimately really boils down to building relationships, because what I do for a living is so intimately associated with a completely different surgeon's practice. I'm fortunate enough to be given the opportunity to care for someone else's patient. They sort of become my patient at that point, but it's a very different relationship than kind of how you train typically as a surgeon, where you're kind of the captain of the ship, you're directing traffic, what have you. So I really ultimately I work for spine surgeons, but I think what makes the relationship most effective is developing a collaborative approach, a collaborative mentality. I think traditionally, if you look at spine access surgeons like my mentors, and in years past, spinal access surgery was a more of a technical discipline. And I think we all approached it in a very siloed fashion. So, spine surgeon does spine surgery, access surgeon does access surgery. So when I made the decision to really focus in and say specialize in spine exposure, I have to understand spine surgery because ultimately this is a spine procedure. The outcome is defined by the quality of spine outcome.
As part of your current collaboration, how does a spine surgeon benefit from working with an access surgeon in an ALIF procedure?
So I think when you build that relationship between a qualified spinal access surgeon and a spine surgeon, I think first and foremost, the impact is intended to increase the safety and decrease the relative risk and stress on the spine surgeon themselves. Let me absorb a lot of the thought process and the technical demands of mobilizing the great vessels and exposing the spine, regardless of complexity, so that the spine surgeon is able to do what he does best. Let me deal with all the soft tissue, the blood vessels, and all the risk that's incurred with that to afford an excellent wide midline exposure to the spine. I think that the second element of benefit to spinal access surgeons as a whole is to really minimize the risk of the approach, reduce the morbidity of getting down to the spine. That means smaller incisions, less tissue trauma, rare, if any, vascular complications specifically, but also the other complications that are associated with these procedures. So in my practice, I've taken it a step further and developed a risk stratification protocol and tool, in part what you see here, that focuses on patient-related factors, things like past surgical history and the nature of those histories, past spine history, et cetera. But then also really puts a great emphasis on utilizing imaging as an objective tool to define patient relative risk for each individual patient, and also address the surgical plan or approach plan that will benefit the patient maximally and reduce risk as well. We found that there's three critical objectives or components to imaging review. First being skin to spine depth, which we'll talk about here in a second. The second being the absolute location of the blood vessels relative to the spine. And the third being we term it the retrovascular fat plane. Basically, it's sort of a white stripe or a fat pad that you can see readily on MRI if you're looking critically for it. And it represents a relatively preserved surgical plane to utilize to move the vessels out of the way. It stands to reason, hopefully, that the skin to spine depth is the most important independent predictor of risk and complexity when doing anterior spine work. And it really drives my decision-making process for how to approach the spine. If we need to do another position, like a lateral position surgery, these things are all tied to that. But I think the key is, again, going back to being objective, being as objective as possible, and understanding that there are physical limitations to approaching the anterior spine, namely the physical depth from the skin down to the spine. So instead of using kind of arbitrary measures or things like BMI, which is a poor surrogate for the real question we're asking, which is how does the patient wear their weight? We use CT scan preferentially in larger patients to define that exact dimension, skin to spine. So that allows me to tell a spine surgeon, to tell the patient, one, the feasibility of the operation as planned, two, the relative risk and level of complexity associated with it, and three, very practical things to communicate with the spine team, like How long is the procedure going to take? Is it going to take longer? Things of that nature. It also ties into the element of what we term the subcutaneous to visceral fat ratio. So oftentimes we associate that with male body habitus versus female. In this case here, you have a BMI of 41 male patient and a BMI of 41 female patient on the right. You can see their body habitus appears totally different. Female habitus tends to kind of flatten out and reduce that distance potentially to the spine, whereas the male body habitus is typically sort of that round or protuberant abdomen that doesn't move at all, no matter what you do. So they're very different dynamics. I think, again, the way to be most objective here is to look at the subcutaneous to visceral fat ratio, not necessarily male versus female. The retrovascular fat plane piece that I mentioned, again, this is information that I get off of a T2 weighted axial MRI. So if I'm working with a spine surgeon or new colleague, this is the first thing I'm going to ask for is, can you please send me images or give me access to the patient's preoperative images? Stands to reason no patient's going to have spine surgery without some form of pre-op imaging. A lot of patients have an MRI. And again, the value add of that is being able to recognize that this little white stripe on the left-hand image that lies behind the left common iliac vein tells me that I can readily move that vein. So regardless of the fact that the vein's not in a great position, it's completely covering the disc, I have that secondary piece of information that says I can really lift it right off the spine and relocate it safely and accomplish a safe wide midline exposure, which is my job. Whereas on the right, when that fat plane's absent, that should raise huge red flags about the ability to accomplish the operation safely. And that's a case where I start really considering alternative approach options because I know that this vein is going to be essentially fused to the spine. Not at all to say you can't still do the operation directly anterior, but again, this is how we, I think, need to think about this operation much more critically and objectively to define how our approach is going to impact on safety for the patient. The last piece is, again, just I tell patients, this is just the way God made you. I can't really control where your blood vessels lie relative to the spine, but what I can do is accurately predict risk and complexity based on the relative ratio of bare area in the front of the spine relative to the nearest venous structure. Really important concept here is what we're looking at is a midline corridor, because that's where we need to put our implant. And we're looking between that midline corridor, the ratio of bare area to the nearest venous structure. So assuming that there's not severe peripheral vascular disease, arterial disease, that becomes a very reliable standard to predict complexity and risk in our patients. Again, you can see if more of the front of the disc, the anterior portion of the disc, is covered by vein, it can, I'd say, imply at least a more complex operation. I'm going to have to do more work mobilizing that vein, and the relative risk of injury to that vessel goes up.
Thank you, Dr. Schoeff. Could you elaborate on how you mitigate the risks of the adhesion with the vascular system?
Good question, Dan. Obviously, the implications of adhesions to vasculature, specifically venous structures immediately adjacent to the vein, very much impacts on what I do, and moreover, the safety and risk and complexity of what I do. Going back to that slide where we look at that fat plane behind the vessels, that is the best surrogate marker I have preoperatively to say there's a lot of scar tissue here that I'm going to have to contend with as I go to mobilize the vessels. Now, you take that a step further, because we're talking here about native operations. This, say, first time the patient's had a procedure on the front of their spine. In a perfect world, that would be the last operation they have on the anterior portion of their spine. The reality and the statistics of it all would say that that's not always the case. And I'll tell you, my mindset around this whole topic changed right around the time where I decided to shift my entire practice focus to make a living off of doing these procedures safely and effectively. And the issue really for me became the recognition that first index surgery, while it's critical that we do it perfectly and get a great outcome, the harsh reality is things don't always work out that way. And whether it's a case that I did initially or someone else did, I have to look at it as I'm prepared to come back into the space should things go awry. So my mindset really totally had to shift to thinking 2, 3, 5 steps down the road when I'm doing an index operation. It's not about, how do I get in cleanly and provide excellent exposure? It's how do I approach these tissues, mobilize these vessels in such a way and plan to be able to get back in should the need arise. Now, obviously, perfect world, it doesn't, but the statistics would tell you it's at least 1% of the time that you're going to be back there. And guys who do this on occasion would tell you, well, 1% of the time, I'm probably not going to encounter that patient. And that's probably true. The problem is when all you do is this procedure, right? 1% of the time adds up, and it carries not only morbidity risk, but mortality risk when you have to remobilize great vessels. So that really caused me to begin to think about what I can do, what steps I can take beyond just surgical technique to prepare to come back and to be in a position where I'm setting myself up for success in trying to improve the quality of operation the second go around. And so that really led me to begin to investigate heavily barrier products, things that I felt like could interface between the spine and the great vessels. So that index operation, we're lifting the vessels completely off the spine and we're relocating them, right? The process of doing that induces tissue trauma. Just simply, no matter how clean your technique is, you've traumatized the vessels and soft tissue. Take it a step further, and I think this is where anterior and posterior surgery differ. We then go traumatize the disc material, take all that disc material out, and then what we replace that with are spacers or other technologic devices that are oftentimes intended to form bone. And I can tell you as a non-spine surgeon, there's nothing more inflammatory than bone growth and bone formation. So you can imagine now we've traumatized the vein. Now we're setting it back on top of a pro-inflammatory environment that it's intended to be inflammatory. That's what we want. And so that thought to me was very disconcerting. And so it became my priority to, at a bare minimum, try to keep those spaces separate, try to prevent scar tissue from developing between the spine and the vessels, and then provide a platform that ultimately would maintain that separation of environments. So, I started out and my interest was in finding the holy grail of barriers. And kind of the initial question that comes up is, well, we've got these biologic barriers. We talk a lot about them, and I'll key in on that here in a second. But there's also these non-biological barriers, which in fairness to the group, they're a lot cheaper. I mean, that's what the hospital CFO tells me, right? And so then the question becomes, well, why use one over the other? So when you look at non-biologic barriers, there are both permanent, non-absorbable, and then absorbable barriers. We'll talk about that in a second and sort of the implications. But I will say as a category, non-biologic barriers are generally speaking the most effective, especially permanent, in preventing scar formation, right? They do their job largely by sort of encapsulating. So creating sort of a capsule or pseudocapsule around the barrier itself. So it's great at scar prevention. The problem is it's permanent. It's not going anywhere. And so it also becomes effectively a petri dish should a single bacterium get onto that permanent graft. So that to me poses a big problem, almost counterintuitive to what I'm trying to achieve. If I'm leaving behind something permanent that could potentially serve as a platform for bacterial growth and potentially retroperitoneal sepsis, which is catastrophic, that made me pause and say, that's not really the product that I want to be using. So shifted gears, looking into the biologic market and what's available. The products that are out there, they absorb at variable rates and in effect become variably effective as a true barrier, which I believe a barrier requires tissue ingrowth prohibition. We got to inhibit tissue ingrowth to inhibit scar formation that's going to adhere to these vessels. So, again, this is early on. I sort of came up with my wish list for what I was looking for in a biologic barrier product. And I think the key components were first and foremost survivability. To me, a biologic tissue barrier has to function as a barrier first, because if you're not able to inhibit tissue ingrowth, by definition, you're not really going to function well as a barrier. But when you look at the wound healing process, right, there's the inflammatory phase, which is usually the first several days after injury. Again, I'm considering any spine surgery or mobilization of great vessels, for that matter, as an injurious process. Then there's the proliferation stage, where cell signaling becomes a major component of the scar or healing response in that local environment. And then you talk about the remodeling phase, which is really what ensues after that proliferation phase. Once you're out of that cellular influx and fibrotic localized phase, then you shift to this remodeling phase, where that scar begins to remodel into something functional or semi-functional, more similar to what the patient's native tissues were like, although never achieving that. So I really need something that's going to survive well beyond that proliferative phase. And the product that I've come to use, the amniotic barrier that I use, has been demonstrated in situ to be existent well beyond the 8-week mark. So now we're way past that proliferation phase, that sort of maximal inflammation phase. And now it's present as part of the remodeling phase as well. When you look at histologic examination after use of this product, you see on the left, when the product's used on a posterior approach to wrap the dura, there really is no discrete separation between the fibrotic or scar formation that happens and the dura itself. This is in the case of using no barrier. Shift gears, use a barrier, and to the right, you see a very clear or cleft-like appearance, separation between that fibrotic scar, which is still going to form, and the dura itself. So it lends itself to obviously reaccessing the area and the implications of reoperation in that space. It certainly gives me much more confidence going back in to revise an anterior construct, knowing that a barrier has been left behind. Now, in a perfect world, everybody would use it ubiquitously. That's not always the case, but I know in a patient that I've operated on previously, I've got a distinct advantage to reaccessing that space.
Thank you, Dr. Schoeff, for that information. Could you tell us more about your technique placing an amniotic barrier?
My personal preference and strong belief in the product that I utilize called AlloWrap is that there are unique properties to various preparations of amniotic tissue. So I did a lot of homework before landing on this product as my go-to product. But if you look at the basic science and you look at the data that I've shown, the survivability of this product, which I think is of the utmost importance, if you want a primary adhesion barrier, the survivability is undeniable. In my personal practice, I have gone back in for revision operations in cases where I've already operated on that patient, and I found viable product, histologically viable product, up to 9 months post-operatively. And so that puts us so far beyond that proliferative phase. We've maintained an intact tissue barrier, just exactly as I want to have, and it's survived that hyperinflammatory phase. And now it's actually supported the native tissues reforming and remodeling into a functional scar. So this product has become my go-to. And as you can see here, it comes in a couple of different formats. Basically what's termed a wet, so it's kind of pre-soaked in saline, and a dry. The dry, I think, scares a lot of people off because it definitely looks tissue paper-like, and it is fragile. If you ripped at it, it would tear. But I find that I actually like the dry product in the setting of anterior spine exposure because it tends to absorb the local fluid that's developed from the operation and then easily conform and almost stick to the spine preferentially. So my technique of application in any given procedure is I actually just lay the product down flat on the spine. And you'll notice to the right screen is the left common iliac vein that's been mobilized and exposed. And so I'll quite literally go in with a pair of DeBakey's here, and I'll pick the vein up off the spine, and then I'm just going to tuck the tissue barrier under the vessel itself, so that when I let the vessel back down, as you see here, the vessel's nice and happy. And it also ends up providing that additional mechanism of adherence, sort of pressing the barrier against the spine, so that I don't have to physically fixate the barrier with suture or tacking material. And then I really just use the peritoneum itself as the secondary reinforcement for that adhesion barrier. So when the peritoneum rolls back over the barrier, it really snugs it into place. Again, in my professional experience going back in and revising these cases, the barrier is remarkably intact, and it's remarkably in the same location where I left it. So I find that to be a very, very advantageous technique. Now, obviously, you could stop short of the extent of coverage that I'm getting here. But again, I'm really focusing on not only adhesion prevention, but truly separating those local environments, so that I have these fragile soft tissue structures separated by a physical barrier to that hyperinflammatory bone formation process that's going on in between the vertebral bodies.
Thank you, Dr. Schoeff, again. The discussion thus far has focused on ALIF procedures. However, are there other spine procedures where adding an amniotic barrier may be beneficial?
That question is pretty broad reaching. And if you look at the literature, there's really a paucity of data as it applies to anterior spine procedures. Where the data really lies, and I think is very, very valuable and at least suggestive of utilization of barrier products, is actually in posterior spine surgery. The hard part in a lot of posterior procedures is the incidence of revising or returning, reoperating in that space. We know that if you have to reoperate in the space, the risk, the complexity skyrockets, and so too does the cost. But it's hard to pin down who's that one patient that's going to need reoperation, right? My strong feeling, at least with the mortality concerns and implications of anterior spine surgery, is that we should be using a barrier product in every patient. In the posterior spine, I don't think there's any debate as in regards to literature and the science of utilizing barrier products in laminectomy sites, in microdisc sites to separate the dura from the adjacent disc material, and then also for nerve wrapping as well. I think the implications relative to epidural fibrosis and chronic pain makes a strong statement towards being intentional about how we protect those tissues during the recovery phase from surgery. So that's where I'd encourage the audience to really do a deep dive into the product you're using.
Dr. Schoeff, thank you for sharing that. Can you provide any concluding thoughts or recommendations on the use of amniotic membrane as a tissue barrier?
I think the last thing I would bring up is really the cost implications of biologic tissue barriers, because without fail, that's the go-to question that comes from our new product committees, our purchasing entities related to our practices. And I'd simply point out that while the cost of an amniotic tissue barrier may seem high on the surface, what we really have to consider is the actual cost of scarring. Can we put a number to that? I think we can. When you look at the data that exists around failed back surgery syndrome, which has a little bit of a nebulous definition, but it's really intractability or inability to progress to a more functional status following spine surgery that ultimately winds up in reoperation or need for reoperation. When you look at the numbers, 40% of patients who undergo an index spine operation will fall into that category. It's a high number, and I think the most common cause that's referenced in the literature or rationale is epidural fibrosis, particularly for posterior spine procedures. Obviously, in anterior spine surgery, it's fibrosis to major vascular structures that may be prohibitive for reoperation. If you consider then that 10% of all patients undergoing spine surgery will ultimately need revision, says to me we're going to be back in these spaces, and we have to really think critically, not how we do the index operation, but how do we do the index operation to present the safe opportunity to re-access that space if reoperation becomes necessary? If you consider that the annual healthcare costs associated with failed back surgery syndrome, again, that includes pain management, that includes imaging, that includes rehospitalization, reoperation. When you total it all up, it's a $20 billion a year spend in the United States alone. So that's kind of my frame of reference when I have to go to a new product committee and justify my use of a human amnion barrier product as it relates to my practice. So I'd encourage the audience to kind of think holistically about this process and the decisions they're making in context with their patients. And I imagine most of us, if not all, will see the value of utilizing tissue barriers more often in our practices.
That was an outstanding discussion. Thank you again, Dr. Schoeff, for a great class. And thank you to our audience. Thank you also to Orthopedics This Week for hosting this event. Finally, a recording of this webinar will be available over the next couple of weeks at allosource.org and otwbroadcasting.com. So please watch for that. Should you have any questions, please reach out to Allosource at the contact information shown. Have a good night and thank you for your time. This concludes our webinar.